Hey everyone, good evening, Happy New Year. This is Dr. Sullivan with you with another I Care for Your Brain lecture. Tonight we're talking about an issue that is very near and dear to me, and it's kind of odd that I don't talk about it more because it really is the reason that I am a neuropsychologist, and this topic is Alzheimer's disease. This is the life experience that I had with my grandmother who had Alzheimer's when I was a teenager that really left a huge impression on me because of the toll that it takes on the human being and the way that it affects people's identity and their family relationships. And over time, I got more involved with different levels of care for people with dementia, different types of dementia. And that eventually led to my PhD in clinical psychology. And here I am in front of you today. So any of you out there who have been personally touched by Alzheimer's disease, you know exactly what it is that I have been through, what my family went through. And it's intense. It's very transformational to go through those kind of experiences. And so I've done all sorts of research on Alzheimer's. My doctoral dissertation was about the visual deficits that happen in Alzheimer's disease. I specialize in patients living with dementia now in my private practice in North Carolina. But for some reason on this I Care for Your Brain lecture series, it's not a topic that we talk about a lot. So someone Facebook messaged me recently and asked me about the new Alzheimer's vaccine that was ready to be released. And I thought, that's funny. I haven't heard about that in scientific circles. So I thought, let me just make this a lecture topic. And that way I will have a chance to research it and I can get back to you all, letting you know exactly where this stands. Well, this is a great topic for I Care for Your Brain because it's a classic example of things that are portrayed in the media about the brain being hyped up much beyond what is actually happening in the world of science and scientific interventions. Yet there are kernels of truth, kernels of progress that are very important that I want you to know about, but are we really on the cusp of the Alzheimer's vaccine? Unfortunately, we are not. But there are things that are happening. There are very significant leaps that are getting us close to a vaccine. So that's what we're going to talk about tonight, is exactly where are we on the science of a vaccine. So many of you know that we are experiencing a huge explosion in the number of people who are being diagnosed with Alzheimer's disease. And that's really happening for a few reasons. One is the world population is aging. This is the graying of America, so to speak, the silver tsunami. We are having all of the baby boomers get into their 70s and their 80s. And dementia, Alzheimer's disease, is an age-related condition. Age is the #1 risk factor. It's not an inevitable part of aging, not as a stereotype, but it certainly is the #1 risk factor that pushes people into their brains developing the disease changes that are associated with different types of dementia. But also we are getting better at diagnosing Alzheimer's disease, and that is very important because the treatments that exist now that I want to talk to you about tonight are very much helpful and useful to their maximum extent the earlier you get them into the brains and the bodies of people with Alzheimer's disease. So there's been a lot of emphasis on early diagnosis, and really the gold standard, if you're not in a very high-level university clinical trial where they might be using very expensive neuroimaging techniques, is neuropsychological testing. And this is what I do in my practice. This is what clinical neuropsychologists do every day, is using cognitive testing, interviews with people and their family members, medical records. Sometimes neuroimaging can be helpful. Our job is to put it all together and figure out what is the pattern of impairment going on with this person, how are they doing in everyday life, to get to the point where we can say this is more than normal aging. And then of course what we really care about is, well, if this is dementia, what is the subtype of dementia? Many people think that Alzheimer's is the most common subtype of dementia, but that's actually debatable. What we really think is probably mixed dementia is actually the most common. And what that means is when unfortunately people have more than one disease happening in their brain, that's resulting in the cognitive impairment. So people may have some mini strokes and Alzheimer's disease. They can have something called Lewy body dementia and Alzheimer's. Maybe they had a stroke and they have a little bit of Lewy body. So there's all sorts of different subtypes that can come together. So probably mixed is the most common, but we're going to talk about Alzheimer's tonight. So the Alzheimer's Association predicts that by the year 2050, there will be 14 million Americans affected by Alzheimer's. So this is about 1 in 3 older adults. In the time period from 2000 to 2015, the rate of deaths from heart disease actually went down by about 11%, but the deaths from Alzheimer's disease actually went up by 123%, which is alarming. But really, it's because of those factors I mentioned to you before, that we're just getting older, so more older people means more Alzheimer's, and we're getting much better at diagnosing it. A very similar thing happened in the world of autism. If you look at the diagnosed cases of autism in the last 10, 20, 30 years, it's really, really exploded, and there may be some contribution from environmental factors, but really what brain scientists think is we've just gotten a lot better at actually identifying and diagnosing these things. Also, we've gotten really strong public education about heart disease, and it's much more modifiable than the diseases that go into Alzheimer's disease. So what exactly is Alzheimer's? It is a progressive neurodegenerative disease of the brain. It comes along with a huge social, personal, economic burden. It typically has a very slow start, almost to the point where it's hard to put your finger on when it actually started, a very gradual onset of symptoms. At times, though, it can look like a rapid onset, but that's usually because people have been compensating very, very well over about a period of 1 to 5 years, where it's almost hard to detect unless you know someone very, very well. But usually something happens that unmasks the Alzheimer's disease. And this can be anything from a urinary tract infection to a fall, to a spouse dying, a spouse going in the hospital and not having that level of support every day, abruptly stopping a medication. There's all sorts of things. It's a very, very slippery slope, and one little thing can change and all of a sudden it looks like the person has taken a big dip down. But really, Alzheimer's disease at first is actually a very, very, very slow progressive condition. There are really 2 different genetic subtypes of Alzheimer's disease. We have early onset and we have late onset. What we all think of as Alzheimer's disease is the late onset. That's after the age of 65. You think about it when people get older, that they start to develop memory problems. And that's true. That's about 90 to 95% of people with AD. But we do have the early form, unfortunately, which is anywhere from the age of 30 to 60. And this is about 1 to 6% of people. Typically, Alzheimer's disease starts in a very specific part of the brain, which is called the parahippocampal gyrus, which is right next to the hippocampus, which is the memory part of the brain. What the parahippocampal gyrus does, though, is it helps us make new memories, and we get to storing them in the hippocampus, and then they go on to the outer cortex of the brain. That's kind of the library where we actually store the memories. But where we chemically make and encode the memories is the exact area where we know that the disease plaques and tangles of Alzheimer's begin. So this is why you see some of the very first symptoms as repeating, having a hard time remembering where people left things. And even more than that is cognitive tasks that where a few different skills come together. Okay, so this is why driving and being able to remember where it is you're going from and going to is a very important part of assessing early Alzheimer's disease, because the memory for how to get places is also a part of the brain where we can see changes. Now, what happens over time, though, is that Alzheimer's disease spreads throughout the brain. So next, if it starts here, it makes sense it's going to spread to the close physical space from where it started, right? So we start to get into other skills that happen in this part of the brain, like word finding, being able to look at an object and call up the specific name. Usually people with Alzheimer's can get close, right? They might look at a shirt and call it a sweater, a pencil is a pen, things that are very, very close in semantic meaning, but they're pulling out the wrong word. Within all dementias, including Alzheimer's disease, there is always 3 areas of impairment. So we have the cognitive symptoms, which we know are primarily making new memories, being able to develop these short-term memories, word-finding difficulties, trouble with visuospatial functioning, parking the car, those kind of things. But we always also have behavior symptoms and what we call functional symptoms. And so behavior symptoms, they actually think might be the very, very first noticeable changes that happen in someone who goes on to develop Alzheimer's disease. And typically, it is manifests as a loss of interest in things that the person used to like and a little bit of irritability. Now that can be because the person is having insight into what's changing and it's scary and there's anxiety, but it can also be that it is just a result of the different disease processes that are happening in the brain. Within the functional world, this is things like not remembering to pay your bills, having a hard time remembering to take your medication, and trouble with the driving that I mentioned before. So when does something tip over from normal aging into dementia? It's when those functional abilities decline to the point where someone can't do them independently. These are called instrumental activities of daily living, and people who have dementia can't do these things on their own. So if you get worried about dementia in yourself or someone else, a very important thing to do is look to real life. Don't look at the repeating, the asking the same questions, having trouble remembering where they put their keys. Those things can happen for a few different reasons. How is the person doing maintaining their independence in everyday life? Within Alzheimer's disease, there are 3 stages that we think of as neuropsychologists: mild, moderate, and severe. I know a lot of times on the internet they talk about 7 stages of Alzheimer's. That to me is much more of a media creation than it is the way we talk about it in science or clinical care. I just think of it as mild, moderate, or severe. So what are the disease changes that actually cause Alzheimer's disease? These are plaques and tangles, and I want to tell you what those are. Plaques are made up of a protein called beta amyloid, and these are changes that happen between the cells. So you've got one brain cell here, one brain cell here. These are called neurons, right? In between the neurons, which of course, neurons need to communicate with each other in order to get their information to and from each other. These plaques, this beta amyloid, builds up and it blocks the communication between 2 brain cells. But then we also have something called tau, and these are the tangles, and this actually develops within the neuron, so actually in the middle, and really suffocates it to the point where it can't get any nourishment and it dies. There are very big controversies in the brain world about what is the leading cause, the plaques or the tangles. There are brilliant people working right now devoting their entire careers to whether or not it's the plaques that lead the way for Alzheimer's, or is it the tangles, the beta amyloid or the tau. And people are very passionate about, I've been at international conferences where they have 2 scientists go head to head and they each make their case for why it's really a tau issue, why it's more of a beta amyloid issue. The current thinking that most scientists accept is happening in the Alzheimer's brain is called the amyloid cascade hypothesis. And what this says is that the first thing that happens are these beta amyloid plaques build up. So remember, these are the ones between the cells. And that after a certain tipping point is when the tau starts to come in. So the idea is that all of these changes with beta amyloid are actually happening about 20 years before you start to see the clinical manifestations of Alzheimer's. And that's what I mean by behavior changes, trouble with memory, and trouble in everyday life. So one thing that you have to think about is that with the current treatments for Alzheimer's disease, one very clear problem is that we're starting much too late. Because once we diagnose someone with Alzheimer's, these things have been happening in the brain, building up slowly for 20 years. It's like by the time someone has a stroke because they have too much cholesterol in their body, that cholesterol has been blocking the blood vessels for years and years and years and years and years. And you can't exactly reverse that damage once it blows over into a crisis or a problem, right? So whether or not it's the plaques or the tangles, what happens is brain cells are dying. And overall, the size of the brain, because it just doesn't have as much content, is shrinking, okay? And this is called atrophy. So what you see if you actually look at the Alzheimer's brain on autopsy or in a picture like a CT scan or an MRI scan is that you see a shrunken brain, okay? Everyone's brain shrinks to a bit of a degree as we get older, but really Alzheimer's is characterized by significant atrophy. How do we diagnose Alzheimer's? I told you before, the gold standard is neuropsychological evaluation. And the key here is that we have a very important distinction between structure and function in the brain. This is probably the most critical concept in brain science, that if you're interested in the brain, if your life is impacted by a brain disease or a brain disorder, understanding this is absolutely critical. The way the brain looks is not the way the brain acts. You can have a beautiful picture of an MRI, a brain in an MRI, and it looks wonderful and there's nothing you can diagnose. And when you actually start to look at how this brain functions, how it is able to learn and remember and pay attention and find its words and how it's doing in everyday life and what its mood is, you might see significant problems. There's big dysfunction there. There's not a one-to-one relationship between the health of the brain at the cellular physiological level and what the brain does. And this is really moderated by something called cognitive reserve. And what this is your whole lifetime of deposits in your brain bank, the quality of your education, the complexity of your jobs and your hobbies, the quality of your social life. That's why I talk to you guys so much about what are the proactive preventative things you can do for brain health. How can you make more of these deposits? Because the idea is the more you have in this account, the more the plaques and tangles, the disease of Alzheimer's, can take out what you have in the bank before you actually start to get into a deficit. Okay, so this is why, again, we want people to be diagnosed as early as possible, because we want to do everything that we can to educate people about what they can do to beef up this reserve. Okay, so there's many reasons that you want to advocate for a comprehensive neuropsychological evaluation if you are concerned about yourself or someone else, and getting treatment as early as possible is a biggie. We also want to reduce other factors that are making the Alzheimer's worse. I have seen thousands of patients with Alzheimer's. Very rarely, if ever, is it just Alzheimer's. I always think of a layered cake analogy. There's almost always something else going on medically, socially, psychologically that is making the symptoms of Alzheimer's look worse, okay? Whether or not this is the person needs a new hearing aid, whether or not they have chronic pain, whether or not they're not taking their medication consistently. We can almost always, as neuropsychologists, find other contributing factors. Of course, if something's going on with someone you care about or yourself, and you're not certain what that change represents, that's a cause for anxiety. So a big part of what we do as neuropsychologists is reduce uncertainty, right, about what exactly is going on. The way I look at it, the worst case could come out to be what's revealed from the testing, or it could be the best case, and I'm able to completely reassure someone and we can look at the testing like a true baseline. But if something is happening in the person's brain, it's happening whether or not we call a spade a spade. So we're going to be in a much more powerful position by actually knowing what is happening. So a good place to start as we get into talking about vaccines is, well, what treatments are available now and how are they not really cutting it? Okay, so the US Food and Drug Administration has approved 2 different types of medication for Alzheimer's disease, and they are cholinesterase inhibitors. We have the class of Aricept and Exelon and galantamine, and that's really when you're thinking about more of the mild early stage Alzheimer's people. And then we have memantine, which is also called Namenda, which used to be that we would bring that in when somebody was transitioning more into the moderate phases of the disease. But now what we think of as the gold standard is that we actually combine 2 different medications from these classes. And really what they do is they prevent the breakdown of chemical messengers in the brain that are responsible for helping to make new memories. So they keep more of the chemical in between those nerve cells. But what's very important to know is that these medications, unfortunately, do absolutely nothing for the disease in the brain. The way they work is that they slow down the symptoms, the expression of Alzheimer's disease. And unfortunately, they're not that powerful. The best that we can hope for is that they have a mild positive effect. Some people get a little bit more bang for the buck. Some people come in and tell me, wow, I really feel more clear. Most people, though, don't really feel that it has a positive effect, and so there's a risk for stopping it. But that's not what you want to do, because really the way it's going to be working is it's not reversing memory loss. It's really not even improving it. It's keeping someone more stable for a longer period of time than they would have gotten without the medication. So remember, this is one of those things that makes you want to get early diagnosis or an early evaluation, is because you want to keep someone at their highest quality of life, right? Let's keep people at the very best stage that they're at for a longer period of time, right? These medications are typically well tolerated. Side effects are pretty minimal, but that's an important thing to talk about with your physician. Typically with Aricept, what you see is about 10% of people have some gastrointestinal issues. Nausea, vomiting, diarrhea. Some people get vivid dreaming from Namenda, and they're typically pretty scary, distressing dreams. Those are the two biggies that I would say to watch out for. Within treatments for Alzheimer's, thank God we're moving away from strictly a medical model. We don't just approach Alzheimer's anymore by saying, here's a pill. We're really getting good at psychosocial interventions, and this is something that is so appreciated by those of us who have lived through Alzheimer's disease. And the idea here is that we're not just trying to medicate the behavior symptoms away, that we're actually trying to understand what is behind the behavior problem, what is the person trying to communicate. And it's really based on respect for the fact that there are some basic human needs for self-expression, to be understood, for comfort, for making meaning. And if we can't do those things with language because we have a brain disease, we will communicate them in any way we can, which is through behavior. It's really us with intact, healthy brains who then label these problems as behavioral disturbance and say these people need to be medicated into compliance. So for a long time, people with Alzheimer's who had these behavior problems were treated with pretty heavy-duty antipsychotic medications, and basically it kind of made them zombies. In the 1990s, we had a beautiful psychologist named Tom Kitwood from England who helped us really revolutionize and personalize the care of people with Alzheimer's. And so he really got us to move towards a person-centered model, which is to say, what is the root cause of this behavior problem and how can we provide comfort to these folks? So right now, any progressive care for dementia is going to involve, yes, some medication for the cognitive symptoms, and sometimes you do need a little medication for the behavior symptoms, but really what we try to do is provide an environment that is respectful and kind and loving to these people. So let's finally get to the vaccine. Okay, that was all kind of a preamble, so the next part of this lecture would make sense to you. So in the mid-1990s, this vaccine word started to go around in scientific circles, and really it started to get going in the early 2000s. So how this all got started is that in some animal studies, so mice, rats, rabbits, these kind of things, they started to inject antibodies to amyloid proteins that were able to significantly reduce the amount of amyloid. Okay, so basically they could put these antibodies in, the immune system would get involved, and it would keep the spreading of Alzheimer's disease in an animal or in a petri dish smaller than it would have been without it. This was very, very exciting. So obviously we started to think about how to do this outside the petri dish, outside of the animal model. And so what they started to think about was immunotherapy, and you can do that really two different ways. And so this is by manipulating the immune system by basically manipulating the way that it reacts to an invader in the brain. So the plaques and the tangles, we want the immune system to see that as an invader, so it basically will munch it away and also not let it multiply and spread throughout the brain. So you can either do this through active vaccination or passive vaccination. So what active vaccination is that patients receive injections of the antigen itself, and the body can make its own antibodies. So you actually put plaques and tangles into the animal and see if you can get the immune system to combat it itself. Passive immunization, vaccination, is where you actually get injections of the preformed antibodies, okay? So they transitioned into making an immunization for the genetically modified Alzheimer's mouse. So this is a mouse who has been designed to have its DNA manipulated, so it is born with mild stage Alzheimer's disease. In the early 2000s, scientists were actually able to start doing some human studies. And so this was a time before I went to graduate school, and I was working at one of the big hospitals in Boston, and they were actually one of the sites for the vaccinations. And I remember the excitement and the enthusiasm, and I mean, never mind for patient care and how this would impact society, but these were scientists that I was friends with, colleagues with, that this would have been major life-changing career stuff, right? So I'm having lunch with these people, and we're all so excited. Unfortunately, there were some tragic events that happened with this immunization, and 6% of the people that were involved in these clinical trials had a severe brain swelling, and there were multiple deaths. And so what happened was there was an autoimmune response, and the lining of the brain in 6% of these people had an encephalitic reaction, and the whole clinical trial was shut down, and people were absolutely devastated. People thought, you know, this was their big break. They were going to make a big contribution to science, but unfortunately there was the side effect in a certain group of people. So there was a scientist in the UK at the University of Southampton who had the opportunity to look at the brain of one of the people who actually got the vaccine who didn't die. She lived, but she had a traumatic fall and she died because of the fall. So this was a great opportunity to be able to look at this brain. So she got the vaccine, she tolerated it well. What actually happened to the plaques and tangles? Well, they found this woman's brain successfully reduced the amount of plaques and tangles in her brain, but they also found some evidence that there had been what they call a T cell response from the immune system. And basically T cells are not supposed to be in your brain, and when they are, it's a sign that something very wrong has happened. And so the idea was that led us to understanding that was really the problem that happened with the original vaccine, is that some people were having this immune overreaction, and it was damaging normal brain tissue, going beyond the plaques and tangles and causing this very dangerous inflammation. So what they concluded from this is, wow, it really was effective. How can we get the benefits but not get the brain swelling? So since that time, and this is what's in the media now, is there's really been 2 studies that scientists have worked on where they are trying to produce these antibodies that bind to the Alzheimer's proteins, the plaques and the tangles, but don't have this T cell triggering response. And these are called AB42, where people, human beings, are receiving the injection of preformed antibodies, or UB311, which is putting a little bit of the disease into the patient's body and having us make our own antibodies. So I want to tell you about the first one, which is AB42, and this is from the Alzheimer's Disease Center out of UT Southwestern in Dallas, Texas, and it's led by a Dr. Rosenberg. He's the founding director. He's the main author of a journal article that just came out in Alzheimer's and Research Therapy last year, where he talks about this new approach. So what's different that he's doing is, instead of actually injecting the antibody into the muscle, which is what they did in the first studies, he's actually putting it into the skin. And there's this idea that maybe that's somehow giving a little bit of distance from the immune system, maybe over time, because it takes more time to travel up through the skin to the brain, that maybe it can be a slower immune response and we're not getting this big overreaction and getting the T cells. And so what they started off by doing is doing this in the mouse model. And when I was looking at the media reports, the headline is saying things like, Alzheimer's vaccine draws closer. We'll soon be able to cut the cases of Alzheimer's by half. Very promising. But when you actually look at the quality of the research study, yes, it's amazing. Yes, it's very important, but it was done in laboratory mice, and we can't forget that. And there's a big leap from that level of animal all the way up to human beings. And so, yes, in the laboratory mice, the vaccine was able to show that it decreased the buildup of both amyloid and tau. But it really was an overly optimistic spin, I'm sorry to say. And really what they did was they took some speculation by the scientist and really presented it as facts. So they don't really talk about some things like that leap from the mouse to the human. They don't really talk about how much this could cost. They don't really talk about what are some potential risks or downfalls. There's no comment from independent sources. It's really big headlines and really very little meat and not much help in interpreting when will this actually reach the real world. Because those of you who are drawn to those stories either have it yourself or care about somebody that has it. So you see that headline, you're like, oh my God, where can I get my sister to the local, clinical trial? Well, unfortunately, the best guess is that we're at least 5 to 10 years away from that specific study getting all the way up to a phase 1 clinical trial, which is where you just test safety and the effectiveness just in terms of tolerability, right? Can people take this medication and not die? Versus a phase 2 clinical trial, which is, does it actually reduce the plaques and tangles in human brain? But hey, let's not forget what's most important is, how does it impact function? What does it do for memory? What does it do for the behavior symptoms? How does it affect people's ability to remember how to drive, to pay their bills? Those of us who care about function in the brain are dying to know the answer to these questions. And this other study, the UB311, they're not even to the point where they're actually looking at the brains of people who have been getting these immunizations. So let me just tell you a little bit about that. So this one is designed to provoke an antibody response against beta amyloid, just like the other one, clearing it away, and again, trying not to get that inflammatory response, sorry. So this one has actually been tried in human beings. So they did a phase 1 clinical trial with 19 people who had mild to moderate Alzheimer's, and they were very excited to see nobody died. The biggest problems were people had some swelling in the site where they were given the injection, and a couple patients had some agitation. There was one other study where they just observed the people. They didn't do any cognitive testing. They were just kind of watching these people over time. This involved 14 patients. It was finished in 2011, but curiously, they have never disclosed the results or reported them in a scientific arena. So that makes me think maybe it didn't go so well. So currently, we do have United Neuroscience doing a phase 2 clinical trial looking at the ability of this UB311 to is it safe and whether or not we can actually tolerate it, and what are we seeing in terms of function. So this is really exciting, but we do not want to read these headlines and feel that the human application is very close and that it's something that's realistic for most of us, because it's really not. So the main author concluded by saying that at best the vaccine will not be sold on the market for at least 10 years. So what do we take from all of this? Well, this is definitely the most progress that we've ever had getting towards a big breakthrough in Alzheimer's research. We all applaud that. We love that. There are current and ongoing clinical trials in actual people where they're starting to think about cognition and function and how does this actually affect people, not just brains in a petri dish, not just mouse brains, not just is it safe, but how does it actually work? We need to talk about the translation of these studies into actual human functioning in order for it to have meaning, right? Otherwise, there's a big gap there, and the media is just kind of filling the gap with false hope, and I think that that's irresponsible. Throughout the course of my research for this lecture tonight, I came across an awesome website called healthnewsreview.org, and I'm going to post a link to it when I'm done talking. Unfortunately, they stopped in 2017. This is an amazing website. They started in 2005. They've reviewed over 6,000 health-related articles on the internet, and they're so good at giving you the objective interpretation. They critically evaluate them according to a few different standards. They hold news organizations accountable for their headlines, because let's not forget, this isn't just about how many clicks that they can get on their article to sell advertising. This is people's hope out there. People are coming to me. This woman emailed me and said, oh, we're so excited. We're going to get an Alzheimer's vaccine soon. Do you think maybe my sister can get it? People are desperate when it comes to Alzheimer's disease. This is real human emotion, and it's something that's very serious and not something that should just be flippantly talked about in order to sell some ads. And so I think it's really important for us to hold news organizations accountable. And if you see these headlines out there, write a comment or write to the editor and let them know that there was a mismatch between the take-home message that got your attention and when you actually read the content of the article, because you're going to be coming in with critical eyes. You know, how do we go from a mouse to thinking about human beings? It says we're 10 years away, but yet the headline says it's imminent and it's happening very soon. So part of why I'm here is I want you guys to have an objective, truthful voice with all of this brain health news, so that way you can interpret it and make sense of it for you and the people that you love. I hope that this shed a little bit of light on this topic. I hope you learned a little bit about Alzheimer's. It is definitely a public health crisis. It's one of the most difficult things that I've ever lived through. But I have to say, it's in my practice now, it's an opportunity for me to really see love in action every day with the type of care that spouses and siblings and friends are giving people living with Alzheimer's disease. A lot of times it's not easy. There's a lot of changes. It's very hard to see someone change from the way you've always thought of them. But what's so important is that we always remember these people's humanity and the importance to still try to reach them and connect with them. I'm very interested in the social disability that goes along with Alzheimer's disease, which means that what goes so wrong in Alzheimer's isn't just the biology, it's the way that people with Alzheimer's disease are treated in our society, and that's something that we have control over. That's something that we can do better at. And so next time, what I'm going to talk to you about is how to be a friend to somebody with Alzheimer's disease. How is it that you can still make sure that they are socially and psychologically connected? Because I think that's super important. If you thought this was helpful or interesting, I would really appreciate you sharing it. I want people to be informed and educated and empowered. And I really appreciate your attention tonight. It's so nice to see so many of you out there interested in this topic. So thanks again, and I will see you guys next time. Bye-bye.